Well, I don't know about you, Kelly. I thought that was really sweet. I was actually expecting John to introduce us as the resident Thelma and Louise of eCare. We kind of get unruly every once in a while, but we have a lot of fun in the work that we do. As John said, my name is Darcy Litzen. I'm the Business Development Officer with Avera eCare. I'm from Sioux Falls, South Dakota, so way up north. We have that funny accent up there. I know you've all heard a lot about telemedicine just in these last couple of days, but it seems to have been the buzzword all around the world in the last year to 18 months. Telemedicine, telemedicine, telemedicine. That message feels a little bit tiresome. And so what we're gonna actually try to do here for you today is not just give you factoids about telemedicine and how it can be applied, but we're going to actually give you our own experience through COVID, not within just our own health system. As John said, Avera eCare is the telemedicine arm of Avera Health System, which is a rural-based health system up in the Dakotas. We began our telemedicine journey nearly 27 years ago already. And it's been a journey that's kind of slow-moving. And COVID, of course, shed quite a light on that journey and ramped up the awareness and need to really push that along in terms of strategy for healthcare delivery in the future. Again, we're going to give our own health system and our own partnership experience throughout COVID and hopefully shed some light on how we can take some of those guiding principles through that time and apply it for, what the future holds for us in healthcare delivery. So this is a little bit small in order for you to read, but just a few basic objectives and principles that we want to make certain that we cover here today. We, like everybody else, saw that COVID-19 really pursued rapid onboarding and adoption of telemedicine services. Within our own health system, we actually saw an immediate ramp up of ambulatory services and how telemedicine could impact that. And Dr. Rhone and I are going to pepper a few statistics throughout the presentation on that alone. But then what we also had the advantage of within our own health system is leveraging our inpatient and acute services. So from emergency medicine to medical surgical, inpatient medicine in our hospitalist programs, and of course critical care as well, we were really from front to end able to employ telemedicine services and augment and multiply our bedside forces, so to speak. So that was really important for us in order to have that base to move very quickly. And again, we really want to emphasize how we can use that experience and information to move forward in strategies for the future. We've heard a lot of subject matter experts in the scientific field saying that pandemics are going to very likely be a reality of our future, maybe more so than we really want to. I mean, COVID-19 turned our world upside down. But it hasn't been that long ago since we heard about Ebola, since we heard about SARS. And, I think that the data is there showing that this is going to be a reality for us for a long time. So this is one of our leaders within the Avera Health System. We just wanted to start shedding a little bit of perspective from their insights as hospital system leaders, not just telemedicine leaders. So Dr. David Erickson is actually the Chief Medical and Innovation Officer for Avera Health. And he became our Chief Incident Command Officer throughout all of this COVID response. And this quote, he just basically said, one critical decision for Avera during COVID was to keep all patients as close to home as possible. Well, that's been pretty much the driving principle for us at eCare the whole time. Rural facilities, rural communities is who we serve. And so anytime we can keep all of those patients' families in their communities is the optimal choice for us. But we really saw that in COVID too. We needed to rely on those critical access facilities in our outlying communities to really preserve inpatient beds within our regional and tertiary centers. And so Dr. Erickson was very adamant from the very beginning, saying all of our telemedicine services from ambulatory through acute through post-acute services have to be in place so that we can maximize our efforts and we can maximize the beds that we have throughout our 5-state footprint. And so, you know, he was just very forthright about saying 3 things need to be in place. We have to have an incident command center where we are talking to all of our critical access facilities, all of our regional and tertiary centers at least twice a week. They have to really employ the same transfer protocols, guidelines, patterns, not only when a patient has to move to a higher level of care, but in that higher level of care in those regional facilities, we need to identify very early on when we can move them back to their communities and open up another bed in that regional facility. So we already, like a lot of other health systems, had a transfer center in place. That's not uncommon, but we were really able to ramp up those protocols for back and forth throughout that footprint. What we also did was really ramp up our COVID hotline. We already had an Avera resource center, or what we lovingly called our Ask a Nurse hotline. And we basically really bolstered that with additional staff members and additional hours of coverage with multiple staff members to make it a resource center where communities or community members could call in, go through basically a screening process to identify if they had some symptoms, and we could expedite orders to get them through to a COVID testing station. And so kind of a funny story about that. John mentioned that my roots are in nursing. I keep a license, but I haven't really put hands on a patient for quite a while. But, you know, in situations like this, you have all hands on deck. And so I took some shifts at the call center. And one of the coolest interactions that I had very, very early on was, you know, my phone rang, I answered the call, and this gentleman named Hector said, you know, I think I might have some symptoms, and I saw your call center information and thought I better call in. So I started gathering some of his information, you know, putting in basic demographics and asked for his address, and he was from New Mexico. And I said, okay, well, this is, you know, a regional phone number. Are you visiting, you know, the Dakotas or something like that for a reason? He's like, well, no. He said, I'm actually just outside of Atlanta right now. And I said, okay, Hector from New Mexico, you're calling me from Atlanta. Well, he was an over-the-road truck driver. And he said, you know, Avera eCare kind of came up in my Google search very first when I was looking for call centers. And, you know, I think I have symptoms, and I think I probably shouldn't be interacting with a lot of people that I have to drop this load off to. I said, well, that is really very astute of you, and I'm going to figure this out. And so having the background that we've had of being connected in 32 states across the nation with different telemedicine services, we were able to identify his nearest testing station, expedite some orders to get him tested. And he was in a Walmart parking lot outside of Atlanta where somebody came to his cab to test him. And it was just such a cool success story. So, you know, just one of those things that you can identify when you have some experience and some systems in place, it can be applicable in ways you never dream or realize. So just a little bit of a snapshot of where we were, what we experienced throughout COVID, and where we want to go. Obviously, we've talked a little bit about our 25-plus-year journey, almost 27 years now, building that continuum of telemedicine services. Where we were, what that really enabled us to do was provide not only existing telemedicine response, but very, very quick expansion of that telemedicine response, not only with our current customers. So for example, at our Avera McKinnon Hospital in Sioux Falls, we are currently there in our ICU program, covering 26 beds in their typical critical care bed census. However, throughout COVID, we were able to double that in size, more than double that in size. We created 58 beds with the support of telemedicine services. What we were also able to do through things like waivers and regulatory change and that kind of thing is just get people licensed, credentialed, privileged in a very quick fashion. So we could deploy very simple technology such as iPads. We deployed over 1,000 iPads, not only to existing, but new customers just for COVID surge response. And then of course, having the providers being able to get credentialed and privileged under emergency protocols really helped us to move forward in a larger fashion. So where do we want to go? harness what we've got in momentum for the future. We've heard a lot about how a lot of money has been thrown at telemedicine, both from a federal and state perspective. There is a lot of regulatory change that is really, really positive. What we want to make sure is that we harness that and manage it responsibly. I don't know about you guys, but I happen to be, I think, on every single technology vendor list who is saying that FCC funds can be spent for their newest telemedicine product. Well, I think managing the expectations of all of that includes providing a service alongside of it. Technology itself does not fix healthcare delivery. And so that is part of not only harnessing the momentum, but maybe making sure that we manage it appropriately. There is a heightened value and awareness to telemedicine, but I think a lot of people are at that point in time where they identify, whew, yeah, telemedicine really did save us in a lot of different ways. That wasn't a whole heck of a lot of fun, but now let's get back to business as usual. So is telemedicine going to get put back on the shelf? We hope not. And let's just really work at, you know, those strategies to continue that momentum. So I think that one of the other things that we really did learn from the whole COVID experience is that we were getting information from all types of sources, just like you were. And there was conflicting information with all of those sources of and it was just so difficult to sift through. And so what we also really took the opportunity to do is gather all that information, try to sift through what was important, what was not, create policies and different workflows. And what we did was we shared that in our portals on our website with our existing customers as well. So I think that that was a resource that oftentimes was under appreciated and underutilized. But we did see a lot of our customers come back to us after the surge and saying, you know, we were getting emails from the CDC, we were getting emails from, you know, our state leaders, we were getting emails from everywhere, but we knew when we were getting a communication from you guys that you had really cross-referenced all those resources, created policies and protocols, shared them with us, and we didn't have to start from ground zero. So it also gave us a great opportunity to really share in education services. So I'm going to hand it over to Dr. Rhone now to just talk a little bit more about the collaborative work that they did.
So like we heard from your similar in our brick and mortar ER we were trying to figure out where we were going to get PPE. I sat in on incident command. About half of my work is spending time on the road, and that very quickly stopped in March, and I took over working in our incident command, which I think hopefully will be the most interesting time of my career, because I don't think we ever want to do last year again. But I think the one day when I worked bedside ER as well, and you know, when they told me that I was likely going to have to wear a bandana when I intubated a COVID positive patient, that wasn't the best day. And we were there, like we were very close. The day that I got my very own PAPR, that I could put Rhone on the front of it, like that felt really good, because I knew that I had a tool to help in this thing that we just really didn't know anything about. And you guys felt that as well. We were all kind of reeling, like we don't, and we're seeing terrible things online and we're trying to learn about it. And so all of those things we were trying to figure out our transfer plans, like Darcy was talking about. At the same time, we went telemedicine lights up. And so in every incident command meeting, every plan that we did had telemedicine layered into it. And I think part of that was our culture of telemedicine in our area, and it just felt normal. And so that really helped us to bring that to light. And our leaders really understood what telemedicine could do. And honestly, it was something that was going to help us to decrease our exposures to our staff. We wanted to make sure that we were giving quality care to all of our patients. We didn't ever want it to be less than, but we knew that we could give quality telemedicine care in every step of the way. And part of the reason why we knew that was we were fortunate to already have these systems in place on our acute care side. We have a very robust emergency program. We're very used to taking care of very sick respiratory patients. And we're very used to helping with vent settings and just triaging patients and then also moving patients. And so we could quickly deploy that. The other thing that was, I think, just helpful was in November and December of 2019, we had piloted an e-respiratory therapy program. And not knowing that there was going to be a huge respiratory crisis and trying to figure out like how would respiratory therapy kind of fit into our ICU and emergency and hospitalist programs. And having had those 2 months of experience really helped us to ramp that up and help our rural hospitals who all of a sudden had heated high flow that they'd never had before, or BiPAP machines. And even the ones that had BiPAP machines usually just used them as a bridge to transfer, but didn't necessarily keep BiPAP patients for a long time. And I think between the telemedicine programs and our incredible rural hospitals, it really helped us to take care of our surge. This is just our timeline, and I know you can't read that, nor can I, because my eyes can't see that far. But so again, 27 years ago, we started with a consultative service, but with broadband, we were able to expand those services to ICU and pharmacy. We actually have a pharmacy hub in San Antonio here, ER, hospitalist, we do prison care, and on and on. And so then when COVID hit, we were able to really just ramp those up and then offer some extra solutions such as iPads and things like that. Many of our rural hospitals, we've heard, did not have negative pressure rooms in their emergency departments. And if they did, they probably hadn't used them in a really long time. I was helping a hospital in Montana, and they had a patient who was short of breath, and it turned out that he had a pneumothorax or a collapsed lung, and they had to put in a chest tube, but he had been short of breath and had had some respiratory symptoms, and at that time we didn't have testing, and so they just didn't feel comfortable putting in a chest tube in their emergency department. But their one negative pressure room was an old OR that hadn't been used in a long time. And so they took the iPad and we went downstairs, and somebody held me up, and I talked them through, their provider through the first chest tube they've ever put in. So all of those things I think were really, really helpful. So again, we converted our Ask a Nurse into a COVID call center. We had one of the first drive-through testing centers in the United States. We were looking at what was going on in Asia, and we were like, well, this is pretty cool, we should do that. And so, and also we have some pretty rad weather where we live, like it's Arctic most of the year. So you can't just have people walk up or stand in line. We had the same problem with vaccinations. Like we were watching Florida and we're like, they're standing in line outside. I mean, we just couldn't do that. And so we had to figure out ways to keep our staff safe and save PPE at the same time that we were, you know, not freezing ourselves to death. So we had to train hundreds of outpatient physicians on telemedicine in one weekend. We actually trained about 1,000 providers over one weekend, because while we have a lot of depth on the acute side, our outpatient numbers were really not that big. And so to bring them all up to speed so we could keep our outpatient going took a lot of work on our technology side. And then we deployed a lot of mobile equipment, like Darcy said, 1,000 iPads, lots of cameras, and then we created isolation wings and made plans for our long-term care centers. We do an senior care, so we're live in both assisted living and long-term care, who obviously had a terrible year. And so we were able to keep those patients and see them and not bring them to the ER where they may be exposed when that was appropriate. So we kind of went from about 50 outpatient visits to about 2,000 a day very quickly. Again, we trained about 1,000 providers. The system had over 16,000 visits in 1 month, which was unprecedented. It wasn't as many as we had done in brick and mortar, but you guys all know how important that outpatient piece was. And we wanted to make sure that we could still offer care to our patients. We had been doing a hospital at home program with our CHF patients and our pneumonia patients, COPD patients. And so we were able to take that program and say, okay, how can we take care of some of these patients at home? We knew we were looking at the numbers that they said we were going to get for our surge, and we knew we weren't going to be able to manage them all in our hospitals. We just, even with tents or, you know, a convention center, the initial numbers that I'm sure you guys were seeing as well, thankfully we didn't get, but they were really large. And so we put all of our COVID positive patients who were high risk on this program. And nurses, they would call them twice a day. Our very high risk patients got a scale, a tablet that they could do video visits with, a pulse oximeter, and a blood pressure cuff. And everybody, because we got about 100 of those, partly through the FCC grant, but everybody got a pulse oximeter. And so that was really helpful because we actually had some data when we were taking care of them. We could watch them on the video and see how their respiratory rate was, ask them how they're doing, and they knew that they could always check in with us. And at one time we had about 1,800 patients at our peak on that program, and over 300 patients on home O2 that had never been on oxygen before. We had to continually update our protocols on every single one of these programs as things changed, and things changed very often. So we went from like not giving steroids to give steroids to only give steroids to these patients, to convalescent plasma, to TOSI, to monoclonal antibodies. And we were, a couple of things I think that made that hospital at home program so well done was it was never a failure to send someone to the hospital. If they were getting worse and they needed to go to the hospital, that's not a failure. We gave the same treatment at home that they would have received if they were hospitalized. So they were able to receive all those medications at home, or if they could come in, say, to our infusion center and get that and then go back home. So we made sure that it wasn't a less than problem. These are some of the equipment that we deployed. The CART system, something we use for hospitalists, senior care. We deployed several of those. The little machine that you can see on the very bottom there, that's called a Tidal Care machine. That's actually a stethoscope, an otoscope, and a camera all in one. So you can look at lesions, look in the throat. It's actually very good. It's very small, and it's fairly affordable. So we were able to deploy a lot of that technology as well. And this is just to lift up our IT and innovation teams. They were there 24/7. They were in the ICUs, putting up cameras, teaching everyone how to use them. We actually had these in our own emergency department, so that when I would see a patient, we had 2 fixed cameras that like we use in our regular emergency program, but in the other rooms, if there was a COVID possible patient or COVID positive patient, we would have an iPad in there. So I could go into the room once and assess the patient and get things started. But when normally, you know, you're in and out of that room, letting them know chest x-ray's back or this is back, but I could do that on camera. And one of the things that did is it helped us to conserve PPE. The nurses in the ICU and ER could do the same thing. So they could check on the patient, do you need anything? And make sure that they're bringing everything in at the same time rather than in and out, in and out. The other thing it allowed us to do was to kind of be in the room when we weren't in the room. from afar, so we could tell people outside of the room, hey, can you hand in this, so that the nurse didn't have to keep coming in and out. Darcy mentioned we did a lot of educational videos. This is me and my partner, Dr. Katie DeYoung, giving an airway lecture, teaching people just how to do airways a little bit safer. You know, that was one of the things I think that was the most high anxiety initially, is how do I do an airway and not get sick and not expose all of my coworkers. And so we spent a lot of time, even just PPE donning and doffing. Many of us haven't done that since the Ebola, you know, time that we all practiced that. And some of my partners, you know, were probably in diapers when Ebola came out. So, you know, we all had to learn those things again. So we were constantly updating that and sending that out to not just our Avera system, but all of our eCare partners. And this is just a picture of incident command. And I think it feels like we're coming a little bit full circle, because this picture 2 months ago looked really odd because we're not wearing masks and we were pretty close together. And it's kind of nice to see a similar picture here today where we're finally able to come back together. But every single piece of what we did, I think the layering of telemedicine really helped us to support our outside hospitals, because you can't tell a rural hospital that has a limited staff, you're going to be taking care of many more patients than you've ever taken care of, and not put support underneath them. So our programs are all nurse and physician, because we know that you can't just support the physician or the provider, you have to support the nursing staff as well. And it's a workforce multiplier. So they can call us and we can be part of that solution. And this is my actual favorite slide of all of these slides. And it's really hard to read, but the bottom is actually weeks, and it starts in April of 2020 and ends in April of 2021. And this is our COVID positive inpatient count for our system. So we have 33 hospitals in our system. 80% of those are critical access hospitals. And as we've heard here over the last 2 days, a lot of our rural hospitals kept a lot of swing bed patients. A lot of our rural hospitals, really their average daily census, one of them was 0.3, you know, up to 3, 5, 8 was pretty big, you know, and during this process, they were keeping numbers that they have not kept for decades and doing amazing jobs. And part of that was giving them the tools to do so, giving them multiple heated high flow machines, giving them access to respiratory therapy, giving them access to a hospitalist who's been working and rounding on the COVID floor for months, helping them to decide, does this patient need to come to a higher level of care? And if so, we need to help them to find that bed. But you can see at our peak in November, our rural hospitals were keeping 2 to 1 patients. So not to take anything aside from our tertiary hospital, they worked their tails off. We worked our tails off. Saw more sick patients than we've probably ever seen before. But our rural hospitals honestly helped us to share the load, and our leadership really lifted them up. And I think that the other thing that we saw was now they want to continue to, I think, increase the level of patients that they're able to keep in their hospitals, and we want to help support them to do that. I'm going to turn it back over to Darcy.
As if nothing else was going on during COVID, the government wanted to get involved in disaster response. And so we kind of said, well, we're not doing anything else. Why don't we submit an RFI to see if we can be a part of that more massive, widespread response? And so some of you may have heard about this, the National Emergency Telemedicine Critical Care Network. It's been something that has been led by Colonel Jeremy Pamplin of the U.S. Army. He's a critical care physician that has a network of critical care docs across the country. And this really brainchild of his has been in process for several years. And so some of our physicians have been connected with him over the years. And, you know, I think we've all heard this saying, never waste a good crisis. This was really the impetus for Litzen to get off the ground and say, we have to find a way nationwide to respond to disasters of all kinds, whether it's pandemic like COVID, or it's a natural disaster that entails a lot of critical trauma, et cetera, et cetera. And so we felt, again, having a good base and wide span of services, that we were just as able as anybody to submit an RFI to participate in this project. And so it was pretty extensive. The application process took quite a while. I believe that there were actually 79 original applicants, of which 9 or 10 were chosen to go through the first phase. We have gone through several phases of this project so far. The first phase was really to identify your structure, your business plan, identify the people and technologies to be involved, those types of things. The second phase was really before COVID surge actually began, but we had the ability to identify sites that we were working with and patient types that could potentially be involved in this type of a response. And then the third phase was just really integrating the technology with multiple hubs in different areas. And so that first slide really showed our initial ideas for what a navigation center with multiple hubs and multiple facilities that we would be connected to. You can see that it got stripped down just a little bit from that first plan to where we're at now, in that it's very straightforward technology. I think that is a lesson learned from COVID, something we can bring forward into Litzen and into the future, is that not everything has to be as complicated from a technology and connectivity standpoint as we once thought. And so we just kind of threw that in there to say that there's more on the horizon for telemedicine in a much grander scale than just what health systems can do to optimize their operations. So I think just really to level set where we're at here is, Dr. Rhone alluded to it. Our rural facilities grabbed onto stepping up to the plate. I mean, they've always wanted to do that. They've always been a huge part of it. But this really shed a lot of light on what the capabilities are across all different facility types within any given footprint. And so we oftentimes think in the rural facilities, we're a little fish in a little pond, and we're ready to jump to the big pond and swim with the big fish. But what that also means is, that bar has been set for the expectations. People are really wanting and grabbing onto that higher level of competency and capability. But some of the same issues exist that did even before COVID. Staffing, that's just a huge thing. We don't have the people and the resources always to continue to provide that level of care. So what do? We saw in rural America during COVID that average daily census really did increase. The acuity levels really did increase. Thereby, the reimbursement levels really did increase. And we were able to keep patients closer to home. So again, we're here for economic development purposes. That's what this whole conference is about, is how do we keep these communities vibrant? And anytime we can bolster the hospitals in those communities, we've really impacted economic development as well. So what are we hearing? We're hearing not only within our own health system, but we've heard this here in some of the Texas, with the Texas partners that we have, and in other regions. Again, their hospitals are really encouraged by the level of care that they can provide. They were very excited to increase their competencies. A lot of facilities, we even heard this here in Texas, there were some state funding that allowed perhaps military assets to come in, where they had some higher level, like intensivist care that was working alongside of some of these rural facilities. And those learnings and those competencies and those capabilities and seeing your community members served in your community, something that people just really didn't want to let go of. But there is that reality now that some of those assets, their time has exhausted and they've gone back to their tertiary or quaternary centers. We still have that lack of staffing. And, it's difficult to recruit and retain physicians everywhere. APPs can be available, but the adoption of APPs, a blended model, hasn't always been fully adopted. But telemedicine support alongside of that is something that I think people are breaking down the walls around. They've seen, what it can do. Telemedicine, of course, is never there to replace anybody, any provider, physician, or otherwise. But how can we indeed bolster those communities and allow them to continue to do what they love to do? Because they did it very, very well. I think that when we talk about breaking down the walls and kind of some of that change management, I think Jennifer even mentioned it yesterday. There's a few things with regard to broadband. It's, is it accessible? And if it's accessible, do you have people to engage with it? And do you have people to utilize it? Well, broadband and telemedicine go hand in hand there. And oftentimes adoption and utilization really does fall within the hands of medical staff, the providers, the physicians, nurse practitioners, physician's assistants that are taking care of those patients at the bedside. And this is just really kind of one of the last items that, one of the last quotes that we wanted to put up there, in saying that from a health system perspective, telemedicine has been a part of the whole journey, but it's been really important for us from the very beginning, number one, to tell people we're not here to replace anything that you're doing. We're here to enhance what you're doing and provide you additional resources. But also the physicians, the providers, all are key stakeholders in the decision-making process of how to move forward, when and why to move forward. And that, in essence, has really helped us in establishing accessibility. That's the easy part, but establishing the engagement and the utilization. If the technology and the service is there, but people just don't feel like it's an engaging process for them and their practice, you're not going to get anywhere. It's going to get dusty on the shelf. So I think that that's just an important key. So when we talk about workforce, here again, we're just really stressing the importance of your medical staff members, your leadership, can identify the challenges in workforce. There's a shortage of people. We don't always have access to specialties. The providers that we do have in our facilities are burning out sometimes because they're on 24/7, and recruitment and retention can be very, very difficult as well. And so again, when you're helping out via telemedicine services and you're multiplying that workforce, and perhaps you're giving a really new practitioner an ability to have access as a safety net to specialized services, it may be much easier to recruit him or her to your rural facility. I kind of go back to Dr. Rhone saying all the time, when she first went through ED residency in Lincoln, Nebraska, she was in a tertiary med center. She was surrounded by all kinds of specialties, neurology, cardiology. If I ordered a drip medication, it just showed up in that little tube, all labeled perfectly to hang on the pole. And, now she's in all of these facilities saying, they don't have that access. I got to work with you to figure out that drip calculation. I got to work with you to, maybe my pharmacist can help you mix that. And so, again, it not only helps those people at the bedside, but it helps to recruit people coming in newly to the community as well. So now I will just turn it over to Dr. Rhone, and she'll give some final stories.
Like half my job is telling stories, and ER docs, we tell a lot of stories, and I'll try to keep them clean. No, just kidding. So we had a different slide for this last year, and we had to update it to people with PPE. But when you have a disaster that comes into your emergency department, and you're a rural emergency department, and I realize I'm preaching to the choir, but you probably don't even have this many people that are there. And at 3 in the morning, you definitely don't have that many people there. But you still have to do all the same work. So when I'm working at my level 2 trauma center and I have a really sick patient come in, I can have 10 people in there doing the work, and I don't have to figure out where I'm going to transfer that patient to and be on the phone and do all of those things and find a helicopter and check the weather and all of those things. And so That's one of the things that we really have looked at with our programs is how do we make your life easier? You know, how can we take some of that off your plate? And one of the things we found is when we're working in tandem doing some of those jobs that have to happen, we actually get those sick patients, if they have to be transferred, out 20 minutes faster. So it was pre-COVID. It was a little bit more difficult, I think, and you guys realize this as well. In the fall, when the whole Midwest was really surging, I had a case in Abilene, Kansas, so different Abilene that we work with. We work with them all the time. I was working with a nurse practitioner named Nicole. She's been up to our hub and spent a lot of time working with her. And she had a COVID positive patient came in. He's 350 pounds. He had no neck. He was on heated high flow, and his SATs continued to go down. They didn't have BiPAP available, and we knew he was going to end up needing to be intubated. We knew he was not going to be an easy intubation. We knew that. We actually had a flight crew on the way, so we were kind of preparing. We spent a lot of time talking about what's your plan, what's your backup plan, what's your backup plan to your backup plan, because this is not going to be easy. And if I could reach through the camera and do it for her, I would have. But one tool that we have is that through her video laryngoscope, where she looks into the airway, we can actually put a cord right in there and I can see that airway on my 42-inch screen. So you hopefully see huge vocal cords, but in this case, we didn't see huge vocal cords. We saw a lot of just pink flesh. And so, but having done a lot of airways before, I was able to say, okay, I think I know where you're at and I need you to pull back, and kind of describing what she's seeing there. Pull up. Okay, now what you're seeing at the very top, you know, that's, and then I want you to grab your bougie, which is this long, thin tube, and I want you to try to get it in there so that we can then snake the ET tube down. And she did an amazing job. We got this guy intubated. We were like, you know, virtual high-fiving and all of that stuff, which we do a lot. But then we didn't have a bed and they couldn't keep this patient there. So we ended up calling 12 different hospitals before we found a bed. So I had 3 nurses and we have everybody's kind of where they usually transfer to, but that was all out of the window in that time. So we were, I mean, like Googling like anybody with, you know, critical care. And so finally got that patient placed for them, but they didn't have to spend that time when they're working with a critical patient on the phone when they only have 3 staff there, because none of the stuff happens, you know, Monday through Friday, 8 to 5. I had a similar case, but a little bit different down here in West Texas along the same time frame. And the patient was actually a seizure patient, but was intubated and needed to go to someplace with an ICU, needed an EEG. That was not something that they could provide there, just they don't have EEG. And so originally we had a bed in El Paso, which I was super excited about because El Paso was having a lot of volume at that time. But then we got a COVID test and it was positive. So we no longer had a bed in El Paso because you have COVID positive beds and COVID and negative beds. And when you're looking for a bed, you're just like, can you just change it? But that, you know, so we had a flight crew there, which was nice because we could put the patient on their vent. And so I had a couple extra critical care people to help with drips and things like that. But what we needed was a bed. And so I actually had them bring the pilot in front of the camera. And our cameras are extremely good. We have really no lag time. So for a signal to come from West Texas to Sioux Falls and back again, it's about 50 milliseconds. And what I learned from the great Mike Easley is that the time that it takes a rattlesnake to bite you is 75 milliseconds. So when I'm in Texas, I like to use Texas terms. It's faster than a rattlesnake bite. So, and you guys have a lot of snakes down here. I mean, we have rattlesnakes, but you guys have a lot of weird snakes down here. So anyway, I brought the pilot in front and I said, okay, I need to know how much fuel you have and how far can you go, because we've looked at every place in Texas and there is no place to go. And so like, should I look in New Mexico, like Las Cruces, or should I go to Oklahoma? Like, or do I need to get a fixed wing because we need to go farther because I can't keep this patient here? And so it was actually kind of fun to do a little air traffic control with him. And, you know, he said, I really can't go to New Mexico because I'll have to stop in El Paso for fuel. And then you have to take the patient out. Taking an intubated patient out of a rig is dangerous. So, so we ended up talking to the most wonderful nurse in a transfer center in Oklahoma City who just moved heaven and earth to get us a bed. So just incredible people working together to take care of patients. We have people who are still just a little bit like, telemedicine, yeah, we used it last year, but now we're done with that, right? And I think we should really think it's here to stay. It's here to stay. It's never going to replace everything that we're doing. We're always going to have hands-on care, but how do we use technology to help us take care of patients in the future? You know, we've seen this with Netflix, with Uber, with Airbnb, and this disruption and innovation, it's already happened. It's already happening. And it can be a good thing. It can be a great thing. So let's work together to do that and to find technology and use it in a way to help our patients and to help our staff. This is Bob Sutton, who's our president and CEO. And I'm not going to read this whole thing, but you know, our primary areas of focus have been quality, access, and workforce. And telemedicine has always been a part of that in our system and then throughout our e-care journey. And, you know, it was like COVID was a huge trial for telemedicine and proved our theory from over a decade ago. So all of the work that we've been doing, I think if you would have asked me in 2019 what my wish would be for telemedicine, it would be for everyone to try it and for payers to pay for it. Well, I got my wish, so sorry that you all had to go through a pandemic for me to get my wish. But now I think there's real work to do to make sure that our payers are still paying for it. Our hospital at home program now, we can only do for Medicare patients because CARES dollars is no longer paying for it, but it actually saves money to the payers. We've proved that. There are a lot of these programs that have been very helpful, and we have to make sure that payers are paying for it. And we have to make sure that we have broadband and connectivity so that all areas have access to quality care and quality telemedicine. You know, and we're looking at things like Starlink and how do we find different ways to get connectivity to those corners that are just really difficult to access. And then we just want to really empower your teams in rural America to just look at telemedicine as an option of something that you can use as a tool in your toolbox. And we want to thank you guys very much for allowing us to come and be part of this conference, which has been absolutely amazing. So thank you. Certainly. Any questions?
First of all, what was your staff like pre-COVID to COVID in terms of constancy factors and, you know, transfer employees? And second of all, have you done any models where you are able to provide this service in a large capacity where they have a PA or another staff on staff industry to be able to provide support that they need to keep their employees?
Sure, a couple of things. So I'm going to address the question about staffing as it related specifically to e-care. All of our clinical teams basically were on full speed ahead. I mean, we did have mandatory overtime, those types of things. Our call center, we bolstered in a few ways. Number one, anybody who had worked in e-care and had a nursing license or a paramedic license was automatically moved into a clinical role. They were essentially reallocated from what their typical roles would be into assisting within the clinical areas. Like a lot of other health systems, our clinics were very much ramped down or shut down. And so we did pull a lot of nursing staff from our clinics into the call center to bolster some of that as well. As far as having telemedicine presence within a major manufacturing organization, we have done that on a what I would consider to be very small scale. So our specialty clinic or our consult model, for example, we have occupational medicine providers that will actually do telemedicine visits for our meatpacking plant in Sioux Falls. And so, if there are injuries on site or minor illnesses and that types of thing on site, we have those specialty clinic telemedicine appointments available. But I do believe that employer-based opportunities are certainly out there. It's always linked to payers, like Dr. Rhone said. But then also one thing that I forgot to mention earlier that I just really wanted to emphasize too from a payer perspective is we saw so much success with our hospital at home. We also do a lot of work with our Indian Health Services in our region and beyond our region as well. And a lot of our clinic visits, we got a waiver in order to see those patients in their home instead of going to their rural health clinic via telemedicine or not. And we saw a decrease in no-show rates in our native population by almost 75%. And so when you're thinking from a payer perspective, and you all are probably involved in accountable care organizations, and population health metrics are very difficult to achieve in some challenging demographics. And so we've seen firsthand within IHS that if we continue down this path of regulatory softening and payer coverage in these types of settings, we can truly impact care for these people.
I think the other facilities, which kind of act like a huge, 1,000 people, and they have a nurse available, and so we work with them 24 hours a day to take care of the prison population and keep them actually in the prison, and unless they really need to come out. And so I think it could be easily adaptable to a work situation or a large plant or something like that.
Do you think from a provider standpoint, is the hesitation? Is there hesitation from providers to adopt this? And if so, what is it, like insurance-based concerns, or why would this be
To help?
to be involved in health?
Oh, to participate?
Yeah.
I think, I think that sometimes change is hard, right? And for 10 years, I have been going to lots and lots of different specialties within our own service area, and no, and then now they've done it and they've gotten a taste for it. Now I think part of it is trying to fit it into their workflow. So physicians and all healthcare workers, we have a certain number of patients we need to see per hour, right? We have a certain amount of work that we have to do. And so if the technology and the workflow is not such that we can continue to do that on that level, they won't do it. And so when we look at a new service line, the technology is almost the smallest piece of what we do. We go in and say, okay, let me see how you get your patients through, and let me see how this is going to work in your clinic, because different clinics operate differently, particularly with different specialties. What are you going to need to be able to do this? If it takes you 10 minutes to upload an image, you're not going to do that. And so we have to make it easier. We have to make the right thing be the easy thing for them, and then we have to pay them for the work that they do. I think is a big part of it. But I think, as healthcare professionals, we're pretty adaptable. We we'll do almost anything to see that patient, but we have to make it work in our workflow, I think is what I've seen.
Thank you so much for your time. I guess it's lunch.